Yeah.
Okay, that's the decisive signals. So, good afternoon, everyone. My name is Boudewijn Nederveld. I'm a computer science professor here in LUMC. And I have been very active in the sales network over the past couple of years. And I'm very happy today that I can chair this symposium joint between Una Europa and sales, actually. And it's a pleasure to introduce Samuel Max and Edris Mahtab, who prepared a very nice presentation on AI in surgical training, and how healthcare professionals of the future will receive their training. So, looking forward to.
Thank you, Professor, for the kind introduction and the information.
Sorry, could you
Yes, I'll go.
tell the online community that we're recording?
Yes, of course. I've just been asked by the organisers to inform the online community that this is being recorded. So that's yeah, just for the privacy regulations. We'll talk about the AI law and privacy later, but it's good that we practice what we preach. As Professor known is Sam, I'm a doctor and a PhD candidate in the Department of Thoracic Surgery here in Leiden, across the street. And together with our PI, Dr. Mahtab, today we're going to tell you a little bit about what we've been doing with VR and AI in cardiothoracic surgery, and indeed how we are aiming to train the professionals of the future. So just to start with, we've got a couple of grants and things to disclose, as well as that we work on the VR platform and the AI platform ourselves, developing that. The agenda for today, and forgive me, forgive the online audience, I'm going to try and face you as well and do a little bit of rotation. I promise if I have my back to you, it doesn't mean that I'm not trying to talk to you. We're going to talk a little bit about what is AI, a very brief overview. Obviously, this is a very learned association with sales, so we won't spend too much time on that. Talk a little bit about what virtual reality is and how we can combine the two to support surgical healthcare professionals, and how that actually we can use VR and AI to impact patient care itself in cardiothoracic surgery. So a very basic definition of AI, and really there are lots and lots, and we discussed this during the staff week in Poland. But the one that I like the most is the ability for a computer system to automatically learn and improve without being explicitly programmed to do so. That's our kind of general header. Then we move down one level and to machine learning. And obviously the two terms are kind of used interchangeably a lot, but there are distinct definitions that I think are important. Please tell me if I'm standing in front of the slides here, I apologize. Machine learning is the subset of AI that is specifically concerns training the algorithms using data. And they can be relatively simple algorithms or they can be quite complex algorithms. But still relatively straightforward, let's say, to explain how they are processing the data, what they're doing, and how they reach their outcome. Then we get to the more complex things. Then we reach deep learning, and that's a subset of machine learning that's using these neural networks, let's say. So that's a much more complex system that sort of mirrors the way that our brain processes information using separate neurons that process the information, that have weights, that have different roots. And these are capable of very complex hierarchical predictions. But the downside of that is that it's much less easy to explain what exactly is going on inside of those networks themselves. So we can make a really nice hierarchical representation of data, but we need a lot of data to train those accurately, which especially in healthcare is a challenge. And examples of deep learning, for example, we can image and speech recognition as well as natural language processing. And I think the most widely known one, as we also discussed in Poland, is ChatGPT, which is a large language model which uses natural language processing to predict essentially language. And that's actually where I want to jump in straight away with our large language program. So on a very, very basic level, what a large language model does is predict what the most likely sequence of words is. So for example, we have this sentence here, the heart is an. We have some different possibilities. Now, obviously, this is very simplified, but we're just going to use 4 different words here. Now, we're humans. We don't need an LLM to know that the heart is and the makes no sense, that the heart is a bicycle, definitely not, and the heart is a joke. That's just offended all the cardiologists in the room, and that the heart is an organ is probably the right answer. But the large language model does that in a more mathematical way and will assign probabilities to each phase, and therefore finding the one that is the highest probability will assign it, and then we have a complete set. Okay, how can we use that in healthcare? This was something that we were pondering as well. Now, this for anyone who's ever been to the doctor, which I'm going to assume is everyone in the audience, this is a familiar sight where you're sitting at a consultation desk and the doctor is sitting across from you, and they're not actually talking to you because they're quite busy writing notes in their computer or they're looking something up, but essentially their attention is that way and not this way, which can feel quite sort of depersonalizing and like someone is not communicating, even if that doctor doesn't mean to do that. The burden of administration is quite high, and it is necessary to take lots of notes, medical, legally, but also just in general, to make sure that the continuity of care exists. What we wanted to do was try and apply a language model, and basically what we do is we put a little microphone that looks a little bit like this on the table here. My pointer is not working. And what we do is we record that and we use a local language model. So that's a language model that's not hosted in the cloud, but that's something that runs on a computer within the LUMC. And it takes the audio, it transcribes it first of all. So it makes text out of the audio, which is a really important step. And then it takes that text and makes a summary of it. So what we can do, for example, is we can generate personalized letters. We can generate information letters that are specifically tailored to that patient, because obviously for our patients, not everyone who is undergoing an operation has the same risk profile, has the same predicted complications, has the same age or any other sort of personalization. There's a lot of nuance that goes into those things. So if you give someone a generic information leaflet, they might see something that's actually very unlikely to happen to them specifically, but might be quite worried about it. So in this way, we can kind of tailor ourselves to the patient themselves. And more than that, we can write the clinic note automatically. So that means that the doctor is not, instead of sort of looking at the computer, typing away, and forgive me, a lot of senior doctors are typing with one finger, so it's not terribly efficient. And it's also just not a great use of resources, you know what I mean? If you've got a senior consultant or a surgeon and you're taking their time to type notes instead of doing what they're best at, first of all, they don't like that. The administrative burden is a huge issue with job satisfaction. And secondly, it's not a good use of resources. And if we can use AI like a local language model to help with that, then that's a fantastic thing. And there are a lot of other programs that are trying to do a similar thing. But the way we try and distinguish ourselves from the other programs is that we are completely local. So that's keeping our privacy people much happier in the LUMC, knowing that the data stays, it gets recorded here, stays here, and gets given to the patient here directly. And that's just one of the many things that we're doing as part of the LUMC group. The LUMC group is the Leiden Amsterdam AI XR group, and we work within the Department of Thoracic Surgery with Dr. Mahtab, who the online audience probably can just about see, is the head of that group. And what we try and do is apply AI to different problems like the local language model that we used in thoracic surgery. So what we've come up with is sort of 6 different areas where we think that we can help. The first one was the language model, which we talked about. We've been doing some more work on image recognition and analysis, and that's something that Ulf will be able to tell me more about. But we have been doing a lot of ECG predictions, so using ECGs to predict clinical outcomes later down the line, which is really nice. For example, predicting post-operative atrial fibrillation, so that we can be there early, treat early, and hopefully improve the patient outcomes through that way. Another really cool one is the surgical hand tracking and education, which I'll tell about in just a second, which uses AI to basically recognize the position of people's hands. And in that way, we try and train models to, for example, recognize someone who is very experienced, or recognize someone who is at the beginning of their learning curve in terms of their surgical journey. And that way, we're sort of more quantifying the actual skill level rather than just the amount of cases that they've done. Then we have the clinical early warning systems, which basically predicts patient deterioration based on live input and feedback. That's the most, let's say, early stage of our development, but that's a really exciting one, I think. Operation planning is something we've been doing for about 4 years now, using virtual reality and a combination of AI algorithms to automatically produce a 3D model of the patient's anatomy, so not a generic anatomy, but the patient's anatomy specifically, to be able to localize exactly where, for example, the tumor is, superimpose an image on that, and then be able to plan the operation accurately. The virtual heart team is very exciting, and I think that's a priority of our department as well, because the heart team has a lot of administration, and what we can do using AI is actually sort of prepare all of this and create a personalized recommendation for that patient before they even get seen. So we kind of remove the sort of human biases and things and sort of proclivities towards one treatment or another. And we create an objective recommendation that then clinicians can choose to follow, or they can choose to disregard. That's absolutely up to them. But what we can do is at least support that decision-making process. And the final one is simulation, and that's the one that I've worked on the most. And that's combining AI to make our simulations much richer. So there's more functionality, there's more things that I can change that will have a real impact. And also be able to sort of guide the participants based on what they're doing. So be able to sort of create a recommendation system for them to be, okay, you did this and this well, you did this and this poorly, next time do that. And that to really enrich the learning experience. And to do that, we're creating a cardiothoracic AI database. What this database is basically a collection of a lot of information that comes from every single device that we use. We know in healthcare we generate huge amounts of data, and a lot of it doesn't get used or get stored particularly. And what we want to do, especially in our little area of medicine, is start this pilot project where we collect live all of the, for example, monitor data, which has all the patients' vital functions, the data from the machines that the patients are hooked up to, their medications. This is a ventilator. Bring all of that. This is a little Raspberry Pi device, so that's a tiny computer that gets attached to each of these devices. That then all gets sent to a secured cloud environment and then gets combined with the clinical data from our electronic patient record, as well as the radiology data that might pertain to these patients. So let's talk about simulation. And this is the bit that I really like. We've been working for about 4 years on simulation, and this kind of came out of COVID as a real genesis for this project. We were facing some issues with in-person simulation, chiefly among which was staff shortages. And it sounds ridiculous, but if I go to the ward now and I say, can I borrow all the nurses to go and do some resuscitation training, the ward manager is going to tell me to go away because that's ridiculous and no one's going to be able to look after the patients. So we need to find some way to sort of asynchronously train our staff. We found that the quality of in-person training was inconsistent, even within certain centers, and access, and we're talking also outside of the Netherlands, was patchy at best. Obviously, limited distance learning, we can't learn to resuscitate patients when you're in that building and I'm in this building. And another thing is if we don't practice sufficiently or sufficiently often, what we know is our skills will tend to drop. And we know that sweet spot is around 9 months, for example, for neonatal resuscitation. So it's something that we can't just do once and then we say, okay, great, I'm trained now forever. Unfortunately, that's not how it works. If we're not doing it regularly, and for example, if we're resuscitating patients, it doesn't happen that often, thank God, but it is something that we need to continually be ready for. We also need a diversity of cases to train for, because obviously some things happen often and some things don't happen often, but that doesn't mean that you don't need to be ready for them. And we need an objective way to assess our people. The reason that we chose VR in 2020 is kind of as follows. I mean, you guys understand what virtual reality is, but it is a really fully immersive environment that we can basically simulate whatever it is that we want. And we can train important skills in a sandbox. So it doesn't matter whether we make mistakes or whether we, how exactly we approach things. You can approach things in a slightly different way and kind of see what happens. And that's both safe, and it means that no one's watching you. So if you make a mistake, it doesn't matter, because you can then correct it the next time. You'll get that personalized feedback. But also it's kind of fun, because you can also see what happens if you deliberately make the wrong choice. And especially I find that experts who use our VR simulations, the first thing they will try and do is break it. And so, for example, our scrub nurses have tried our scrub nursing simulation. The first thing they do is take the instruments and they throw it at the surgeon, which means that, I don't know, maybe they were fantasizing about doing that all along. I won't speculate. But it's a really nice environment to learn in. It facilitates spaced repetition, so the sort of attrition of skills that we were talking about before. It's really important to repeat these trainings often so that we keep them at a good level, so when the worst happens that we're ready. We are independent of the trainer. We're independent of a specific location, a specific room, and the equipment, which can be quite pricey, especially for let's say, low resource centers. And finally, you can do it on your own, or you can do it together. So this is the platform that we came up with. The 4 simulators from right to left are as follows. We have the, and forgive me for the online audience, we have the VR CPR on the left-hand side. That is the most mature simulator. That's our simulator that resuscitates patients after cardiac surgery. Patients after cardiac surgery are not quite the same as, for example, a patient if you were to find them on the street. And that's because they've just had a big heart operation whereby they open the chest. There's a big spreader that opens this up, and it means that if we try and push on the chest too hard, it can cause a lot of damage. And what we actually really need to do is open them up again. And that needs to happen very quickly, around within 5 minutes. That's a big challenge, and that's a big ask, especially for new healthcare staff. So that's something that we really do need to train for. And that's what we've been doing for a couple of years now in this, and that's implemented in this center and a bunch of other centers across Europe and North America. The second simulation from the left is the VR ECC, and I'm going to combine that also with the VR ECMO. These are devices that support our patients. So during the heart operation, what you'll typically do is stop the heart, and that means that we are able then to operate on it or in it, the heart, without the patient having, let's say, massive bleeding. And then the function of the heart and lungs are taken over by a machine, which then helps to provide oxygen and blood to the brain and the vital organs during that period. And the ECMO is a sort of little version of that that's used on the ICU to support patients when their hearts and lungs are not working properly. These are quite complex devices, so you can see there's a lot of buttons, a lot of things that can change, and they're machines, and machines break sometimes. Thankfully, again, not a lot, but these things do happen. So it's important, as with, this looks a little bit like an airplane cockpit in some ways. Just like the aviators train for things when they go wrong, we need to do the same thing. That's really important. Again, these physically to train with these is tough, because you need the room, you need the machine. The machine costs in excess of 100,000 euros. And that immediately for low resource centers means they can't really do much simulation. And that's kind of an issue. So that's why we created these simulations, to train not only the normal circumstances, but also the abnormal circumstances. And then the final one, as I said, is the cardiothoracic scrub nursing. That's the simulator that helps the assistants, let's say, get used to the instruments, to get to know which one is which. And that's something that Maurits, who's sitting here, is working on. He's helping to model the instruments, because your average cardiothoracic instrumentarium might be a couple thousand instruments, and they're all very subtly different from each other. But it's very important that the nurses get to know exactly what is what, and to give the correct instrument at the correct time. Surgeons get kind of grumpy if you don't do that. What we found is it's really important when you're creating these things is to not only do the development, but you have to immediately also do the validation, because you have to prove that these things are not just fun toys that I look at to play with, but to actually do randomized controlled trials and show that they perform as well as the conventional education, or perhaps even better. And that's something I'll come back to in just a moment. This is our development process. So obviously you start here, you have your scenarios, you have things that, you have the sort of design brief, you include people like surgeons, you include the nurses, you include whoever is, the relevant stakeholders to the project, you create scenarios, and then you go to the test phase. During the test phase, you're getting a lot of feedback from the experts, the people that you included in the beginning, but also just going onto the wards, being like, try this, see what you think. And then you incorporate that feedback, often go back to the create phase, and then eventually you head over to the validation phase and you do the randomized controlled trial studies. To just jump to a sort of parallel thing, when we talk about create, we also are using AI at the moment to help us create these simulations, because they offer a lot of tools that mean that we can simplify our development process, but also make it more efficient and more realistic. So what you see on the top row on the left-hand side is the ECMO machine. And this is a photo taken in a very specific environment. And what you can do, actually, this is a real ECMO. If you take, I think in our first run, we took 2,000 photos of the ECMO from different angles and different locations. What you'll end up with is something that is what you see in this next image in the center of the image of the slide. And that is a photogrammetry recreation of the ECMO itself. And you can also see that on the far right as well. And that is a completely photorealistic representation of what it looks like in real life. And that uses kind of an AI algorithm to automatically place where these, let's say, photos are taken from, and automatically generate a 3D model. And that's a really, really nice technique that Maurits is working with now. For example, also for the instruments and for lots of different things, that we can automatically create a model rather than having to do it all automatically. The alternative, of course, is the 3D scanner, which is what you see here on the bottom, emitting blue light. And that we also use for our instruments to make really lifelike representations of those instruments. And this is a little bit what it looks like once you do that. Is it working? Yes, it's working. So what you see here is a very detailed 3D model of, for example, an ECMO machine, which was created on the basis of the techniques that I just discussed. And then once you include that in the simulation, this is roughly what it's going to look like. So you can see it's a really detailed environment that looks really a lot like what the real ICU looks like. And then we have to take it a step further. So once we have a beautiful visual model and we have all the scenarios and we have everything ready to create the simulation, we need to create the system's depth to reflect that, to make sure that it's not just looks really nice, but it works really well. The way that we've been doing that is taking real patient data from the heart-lung machine, from the ECMO machine, combining them, and then also including things from the electronic medical record, the clinical data that I just told you about, put that all into the database, and then using a deep learning model, we've kind of created AI simulations of what those machines are like. So that means if I turn one of the pumps up, or if I disconnect something because I'm being malicious, it reacts exactly like it would in real life. And that creates a level of immersion that goes beyond just a sort of nice visual model. You know what I mean? You can simulate all sorts of unusual scenarios using that. This is unusual. Okay. Cool. So I'm just going to assume that
Click next, please.
Oh,
Yeah,
turn on. The projector is off now. So if you press on the yep.
Sorry, guys. Probably for you, nothing has happened, but in the room, the screen has gone off.
Sam, and click on. Is it on the laptop or on the?
No,
on the PC?
it's here. It's actually the display that's gone off because you can see this is fine.
If it stops, yeah,
Yeah.
it should come on.
See it.
A second, it would. Yeah.
But yeah, here we
Yeah,
go.
there we
Great. Perfect. Yeah. That's it. Yeah. So we've implemented those models in the simulation. And then, as I said, once we've done all of this work, it's time to validate. And that's really, it's an exciting time. It's a sort of nerve-wracking time because you get to see whether what you've built actually has a sort of clinical utility. And in our case, what we did with the ECMO was we took 35 nurses from our department, from the ICU, who didn't have any experience with ECMO yet. So these were novices. And we trained them in two ways. We either trained them from the classroom, just in the way that we would normally train them, or we asked them to do our virtual reality simulation, as you guys just saw. And then what we asked them to do was perform the circuit check, which is basically a set of safety checks to check that the ECMO is functioning normally and that the patient is doing fine. We videoed them all doing that. And then what we did was we scored them based on how fast they did it and how many mistakes they made, because obviously the thing that you're trying to do is make them make less mistakes. And the results are really exciting. What we found was that the VR group made around half of the mistakes that the conventional group made, which represents a pretty strong improvement, and that was significant at this stage. And what we wanted to also do was not only test if the simulation was useful, but also if people enjoyed it, because if a learning tool is useful, it doesn't necessarily mean that people are going to use it unless they kind of find it fun or they find it real, or they, you know, there's a lot of different things that go into that. Thankfully, pretty much all of our participants learned a lot from the simulation and really enjoyed it, and they found the quality also very high. So that was a big motivator for us to continue to put more scenarios into the simulation and to continue sort of increasing the fidelity of the scenario with our AI models. Since we started our program, we've formed a lot of partnerships with different international organizations, including the European Association of Cardiothoracic Surgery, the European Board of Perfusion, and some of our national societies as well, in order that we can train a bunch of healthcare professionals, not just in the Netherlands, but internationally. So you see, for example, actually, this is in a room just a couple further on. This is the first year perfusion students. So these are the students who are going to be using the heart-lung machine in the future. And they're getting their first introduction to the heart-lung machine in virtual reality, which is really cool. So they do that twice a year in their curriculum now, and we're getting great feedback from that. And this, for example, is at the Society of Cardiothoracic Surgery in Birmingham, where we trained around 120 healthcare professionals in resuscitating people, and that was, again, really well received. And actually now we've passed the milestone that we've trained 1,100 people in VR, which we're very proud of, given that we're quite a small team. Actually, it sounds like it's a big business. It's not. It's a team of very small but hardworking people training all over the world. Here you see Barcelona, Manchester, this is the Netherlands. You see all sorts of different locations and all sorts of different publics that we've been training. And it's a really gratifying experience to see how people enjoy it. And it doesn't matter if you're, a high school student or if you're, you're already retired. People are generally getting the hang of it really quick and being able to use it. And so I just wanted to show you a very brief demo of what the machine looks like with it. That's the moment where we're actually stopping the heart. You can see the AI model is predicting things that all the numbers that you see are predicted. You can also see it's a very complex machine. There's lots of things. So it's a very short idea of what that looks like, but what you see is there's lots of different steps, and Edris will tell you that if one of those steps goes wrong or something is in the wrong order, or you accidentally switch on a pump that you shouldn't have, the consequences can be pretty severe. So it's really important that we're not just training consistently, but we're training this sort of stepwise algorithm. That means that every time people follow the same checklist the same way, and in that way you can have staff sort of perform reliably, even under pressure, even in emergency situations. Now we're going to jump to something completely differently. So we've done the sort of pre-intervention training, let's say. So we've talked about sort of VR simulations preparing us for our practice, but now we need to analyze exactly how our practice is. And again, unsurprisingly, we can use AI to do that. Something that we've been working on is our surgical learning curves with AI. The graph that you see here on the screen is a cumulative sum graph of a particular procedure. What that is basically how many procedures it takes to become competent and how many procedures it takes to become expert in a specific procedure. Along the x-axis here, you'll see the amount of cases, and along the y-axis is the cumulative sum calculation. These dotted lines that you see, phase 1, 2, and 3, represents, let's say, the early learning phase. It represents the competence, and then it represents expertise on phase 3. Right now, these things are slightly arbitrary in the way that we define them. We've obviously some of these procedures we've got learning curves for, a lot that we don't. So that's something that at the moment we're busy with, trying to define how many procedures does it take for me to become competent in, for example, sawing the chest into 2 pieces so that we can open it and access the heart. These are actually very simple things that happen on a daily basis. And yet we don't know exactly how much it takes to become competent. We have a guess, we have an idea, but we don't have evidence. But it still remains that the amount of cases that you do is still a sort of slightly abstract concept. And it's not necessarily linked to your competence. There's a good chance that you'll be competent after you do those many cases, but there's not a guarantee. And there's a better way, we think, to actually track how people are learning and how far they are in their learning curve. And that's obviously using AI to track our hands during surgery. This slide contains an image of surgery, just for those of you who do not want to see that. So what you can see here is you can see a surgeon and their assistant, and you can see that the AI model is tracking the hands in sort of 15 or 20 different landmarks. And that's happening dynamically for every single frame of the video. So that happens 30 times a second. For the entire duration of the operation. And that way you can generate a huge amount of data, and it looks at it slightly differently than we traditionally would look at surgical education. And you generate data that looks a little bit like this. So for example, some of the parameters that we're looking at to start with is how smoothly are people moving their hands, because that's a definite indicator of competence. If you're sort of doubting yourself, or you're not really sure about what you're doing, you're more likely to sort of have jerky movements. Whereas if Dr. Mahtab, for example, is operating, all of the movements are very deliberate and smooth, and there's a sort of manner of expertise that even if you can't put your finger on it, that's an experienced surgeon. And the second thing is path length. So that's just simply the amount of distance that the hands move throughout the operation. Obviously, if I go to grab an instrument and I realize I grabbed the wrong one and I grab another one, I'm going to move more than someone who's done the right thing at the right time. And you can see a little sort of GIF of what the hand movement looks like. This is a little bit raw still, but what you can see is that it tracks the hand over a certain amount of time in 3 dimensions. And this is something that we're working on and refining at the moment.
Sorry.
Yes.
Question?
Of course.
So then you can see who's the more experienced surgeon and who's not, but what would you use it for then?
So really excellent question. So you generate a lot of data, and what we're hoping to do is correlate it with the learning curves itself, so that we can actually say, okay, based on our model, watching you operate, you are competent to perform this procedure, or you are an expert in performing this procedure. And what it can also do is give you individualized feedback. So it can say, for example, this part of the operation you do very well, but this part of the operation there is inconsistency, or the stitches are unequal, or something like that, that it can provide you actually with really objective feedback based on what you are doing with your hands. So that idea is not just for people who just want to see how good they are. That's not that interesting. It's for trainees at every stage to see, are they progressing at the rate that we're expecting them to progress, and what are their weak areas that they should work on to make sure that their sort of performance is consistent across the board. So next question.
In this graph, the left part, you see the jerk on the y-axis and the path length on the x-axis. And actually, this is a graph of my hand during the surgery. The previous picture was my hand. I performed here anastomosis, Lehman LAD, so left anterior mammary artery on the left anterior descending on the heart. And you see that my jerk and path length is near to 0. The yellow part, you see? So it means that the whole graph is concentrated on the 0 side. So the idea is that a first-year resident, first-year trainee will end at the 1-1 corner, right upper corner. That's what you want to show, right? So it doesn't matter how good I am, it doesn't matter how beginner the other one is, as long as the graphs are separated. And when it's separated, you can see that they will move together, and hopefully not the surgeon will move to the 1, which can happen, but that the trainee moves to the 0. So that's actually the idea. So when you put the next person here, you can compare those two with each other. Now we have objective way to see someone's competency, not like what we now do is the surgeon and the trainee sits together and says, I like this, I like that. And when the person doesn't like you, you will get the less points, obviously. Or when the trainee doesn't like the surgeon, he will never ask for a for an exam, right? So they never ask the OSAS, as we call it. So in this on this way, we can have the trainee to be evaluated on the best way, but also our selection procedure. So next time, the first time we select someone to get in the training, we could do very simple hand tracking on just piece of paper, and to see how is the hand tracking of this person. Does it fit into the surgical way, or this person needs to be internal medicine doctor or someone else?
Carpenter.
So this is how this is only the first case we did on the first case with this. So
we're still experimenting with how exactly to capture the images so that we're not intrusive during the operation, and still ensure sort of accurate hand tracking and things.
How robust is the hand tracking? I mean, if you have errors of the hand tracking, you get jerk and jitter, everything at the same time.
Exactly, which is a problem, and also because a lot of these hand tracking models are trained on hands.
Yeah.
As in my hand looking like this, not my hand wearing a white glove with blood on it.
That's the biggest problem now.
Yeah.
The gloves are the biggest problem.
Yeah.
It doesn't matter that hand is going outside the scope, because where we work is on 10 by 10 centimeter area. So when I do my anastomosis like this, and once in a while I do my hand here and there, that doesn't matter as long as it's consistent.
Yeah.
But when my residents start, the first trainee, with every stitch, they move their hand like this and go out and come back, and with every stitch. So that means that's the difference. That's what you want to show. That's what you want to show. It doesn't matter that it goes some so now and then outside the scope. But the gloves are the biggest problem now. So we have to solve that problem. That's the biggest problem.
And then we jump to another area where we think that, where we've been using AI for actually quite a long time, sort of before it was cool. And that's in the preoperative surgical planning. And a little bit there, everyone sticks AI labels and stuff, but actually this is really truly an early implementation of that. What we can see here is a recreated CT scan of a patient. So that's a scan of the patient's upper body, and we're focusing specifically on their lungs. This patient has a lung cancer tumor in the right upper lobe here. And what you can see that sort of in pink. But what's really important is that we understand the patient's anatomy, because the patient's anatomy changes a lot per patient. And what we can do is, we've been doing recently an operation where we remove a smaller amount of the lung than we would otherwise do. And that's called a segmentectomy. So the lung is divided grossly into 3 different lobes, but we can divide those lobes even into smaller segments. So we're really just the piece of pie that's relevant for us we want to remove. And that's a nice idea, but it's quite a complicated operation to do, because you need to identify exactly the right windpipe, the air pipe that is going to that particular piece of pie. You need to identify the right artery that's going there and the right vein. And you need to make sure that you identify them correctly during the operation, staple them, and then remove that little piece of pie. And you also need to know exactly where that tumor is. And those are all things that we've been doing with the CT scan for a long time. And obviously there are a lot of doctors that are very expert in sort of taking the 2D image and making it 3D in their heads. But wouldn't it be nice if we could just make it 3D to start with? And in that way, we can plan our operations more effectively. So that's what we've been doing. What we did actually was we implemented this in a sort of nationwide trial. We planned 50 operations, and then we compared, let's say, the surgical plan as made just with the CT scan, just with the normal imaging modality, and then after using virtual reality. And what we found was that actually in more than half of the cases, the plan changed based on the virtual reality. So I think that's a really strong evidence that this has a sort of added benefit versus just planning in the sort of 2D plane. Another thing that we can do with it is that during the operation, obviously, even if you've used virtual reality, that's still just in your head. You know what I mean? That's you're only as prepared as you're prepared, regardless of what modality you used. Wouldn't it be nice to be able to see during the operation exactly where we are, what we're doing, what the structures are, a little bit sort of like Google Maps during the operation. And that we can actually do. So what you see here is this is the image taken directly from the camera. So this is a minimally invasive operation. This is a camera that goes into the patient's chest. And then you see some structures here, but especially if you're at the beginning of your training, it all looks like spaghetti and you're not really sure what's what. What we can do is we can use AI to automatically, let's say, superimpose the 3D model that we created beforehand on top of the patient's, on top of the image that we get from the camera. And in that way, we can identify exactly that, okay, we know that, no, this is the vein, for example, and we know that we can safely staple that and move forwards. And the last little thing that we're working on as well is our patients, when they have the CT scan before the operation, they take a deep breath in, and then the CT scan is taken, because in that way we have a nice imaging of their chest. However, during the operation, their lungs are deflated, because otherwise there's no room for us to operate. Now you can imagine that the anatomy before the operation and during the operation is going to be a little bit different, because a balloon that's inflated is very different from a balloon that's deflated. So right now we're looking at sort of the differences between that, and again, using an AI model to predict what the changes are when a lung deflates. And now we jump to something completely different again. Sorry, forgive me. This is a whistle-stop tour of what we're doing in cardiothoracic surgery. This one is fun because this one's for patients. This one's not for us. What we've been doing with virtual reality is trying to help our patients after their lung operations. These operations, although they're done with keyhole, they're done with a little camera that goes in the chest. You make sort of 2 or 3 holes in the chest. It's still immensely painful. It's a very sensitive area of the body. And these patients have a lot of residual pain afterwards, and unfortunately, a fairly significant percentage will go on to have chronic pain as a result of their intervention. So that's an issue. That's a big quality of life issue, especially for these patients. Obviously, they have cancer as well. That's just another thing that they then have to deal with. There are a number of really innovative pharmacological interventions that have been, aiming at reducing the pain. But there are then actually recently using virtual reality, some really nice evidence that what we can do is instead of giving the patient something, we can distract them from their pain, or we can remove them from the hospital environment and put them somewhere else. So it's a sort of depersonalization in a way. We remove them from the environment and we put them in a concert hall, we put them in beautiful nature. And actually what we've been trying to do is personalize it to the patient themselves. So not just, for me, an Alp would be lovely, but maybe another person wants a beach in Barbados. I don't know. It doesn't matter. The point is you ask that patient and you try and provide an image that they have a connection to. So we've been putting them all together into our app that's called Louvre. And the idea is to distract our patients and reduce their pain, reduce their anxiety. And if we're really lucky, we're also reducing the amount of opiates that they're having to take afterwards as well. And that's something that's a randomized control trial that's just starting in the LUMC now. And hopefully next time we speak, we'll be able to tell you a little bit more about the results. And this is just a screenshot of what the menu of it looks like. So for example, here we're choosing an environment that's in Switzerland overlooking the Alps with the sunrise. And not only are we able to be in that environment, we're choosing also, for example, if we want to listen to music, if we want to do breathing exercises, these are really important for our patients to help them sort of rebuild their lung function afterwards. Or if we want to do mindfulness meditation, which we also know will help to relax our patients and hopefully also bring that outcome sooner. Now is the part of my presentation that I want to talk a little bit about the opportunity that I had recently on behalf of Una Europa to visit the Jagielloński University in Poland, in Krakow. And this was an immensely fun week that we had, where members of the Una Europa network from across Europe, from many different universities, came to Poland to learn, to share what they're doing with AI and sort of try and form research consortia going forwards to broaden our knowledge and work together to implement these tools, as well as sharing best practices.
Sam, you were the person taking the picture because I didn't see you on picture.
I was hoping you wouldn't notice. Yes, exactly. I shared that in my former life, I'd worked for the BBC as a broadcast engineer, and they said, okay, you're the cameraman now. So yeah, maybe I should have AI'd myself into the side. That would have been smart. I missed a trick there. Thank you for pointing that out. So we covered a lot, and I don't want to take you through the entire week, but there's a couple of I think important highlights and summaries that we can go through in terms of what we covered. So that is best practices in AI management. So I think that's an important subject because AI is not just about the technical details, it's also about how we use it, how we implement it, who is implementing it, and what the practices are that they're using. The European Union AI Act is a really important thing because that's the law that now kind of governs how we train, how we can use AI, what the legalities are in terms of what we're using to train the models, all sorts of different ins and outs, which frankly I didn't have that much understanding, but there was a law PhD who came and explained it to us in language that even I could understand. I was very grateful for that. And finally, we talked a little bit about sort of generative AI and creativity, the sort of nature of generative AI. Does it reduce our potential for creativity? Does it increase it? Who owns the output? There's a bunch of different stuff there. So just to sort of dive into a couple of those themes. The best practices that we discussed, or at least the sort of consensus that we came to, was that human oversight when we're using AI is the most important thing. And if we're using healthcare, for example, as a case study here, maintaining human involvement, ensuring accountability and ethical compliance when we're using AI is incredibly important. So at the moment, it's still not entirely clear if I use an AI model to predict something for my patient and that's the wrong thing and the patient comes to harm, who is it that's to blame? Is it the person who trained the AI model? Is it me for using it? Is it another company who perhaps provided the machine that it runs on? There's a lot of different variables there, and that's something that we're sort of just figuring out. But there's a lot of legal stuff, I'm informed, that is still very much not decided. Then we talk about risk management. What are the best practices in terms of risk management? And I think the most important things that came out of that was that we should implement our tools first in a sandbox environment. We need to test them in a safe environment to check that they work like we think they work, They work when clinicians are using them, not just technicians, because we all know that software, even designed by the best people, sometimes can have unintended effects when users actually get their hands on it. And we need to also indeed identify potential failures or biases. And that's really important again, based on what is being trained on, we can induce a lot of different biases that we don't necessarily know about until we use these tools in practice. Avoiding using personal information, obviously, unless that's really unavoidable, but actually according to the EU law, we really should be using anonymous information now to train our AI models. Fairness and transparency, as I said, we're using diverse training sets to minimize bias. Again, that's something that we've been seeing in the large language models like ChatGPT, that there are some inherent biases just based on the fact that it is trained on the whole internet, more or less. There are things that we need to look out for and make sure that we avoid those pitfalls. I think this is an interesting one, providing clear explanations of AI decisions to users. Explainable AI is a field that is, I won't pretend to understand, but there's a lot of talk about it now, especially in healthcare, because we don't just want AI to help us make decisions, but we want to know on the basis of what it's made decisions. How has it used its inputs to come to a conclusion? That's very much easier said than done. My technical colleagues can tell you much more about that, but essentially that is something that we are still working on now. And if we can use best practices to implement as much explainable AI as possible, it means that our decisions are more reliable and perhaps less affected by bias or the other sort of pitfalls. And the last one, I think, during the staff week, there were a lot of university administrators present, and their concerns were very focused on students using generative AI like ChatGPT, like Claude, to generate assignments or other things. And we talked about what can be done about that. And that's a really difficult question, because the one thing we do know is that if we use AI to try and detect AI, it doesn't work very well. There's a huge amount of false positives, false negatives. It's just a really poor system. So you end up sort of, making false accusations. It's not a great idea. So instead, we have to sort of build a sort of, how to say, an AI literacy amongst not just students, but also staff, and open a conversation that if someone is using it, that they have appropriately, let's say, credited that they have used generative AI, because using it is not necessarily an academic offense, but that there are sort of certain stipulations and pitfall, let's say, guidelines and regulations for each university about using it and how we can harness its creative power without, let's say, using it as a tool to write our essay at the last moment because we forgot to do it. And I think that when we come to education as well, that's incredibly important, because we are now coming to a place where AI is going, at least if you believe Mark Zuckerberg, is going to replace some of its mid-level engineers doing the job of coding, for various things, and that's going to be true of many other industries. How we can preempt that by creating education programs that reskill people and mitigate, let's say, the effects of AI taking certain sectors of jobs. And I think that's something we should be thinking about sooner rather than later, as well as educating users more generally about its capabilities, limitations, and ethical implications, not just students, but everyone who is using it. And again, very quickly, just to go through the sort of highlights of the EU law that's coming in now. There are 4 levels of risk that the EU defines for the use of AI. The top tier is basically prohibited. We can't use that at all. That's if we're sort of implementing like a social credit system automatically, or we're profiling people or something like that. That is absolutely unacceptable risk that should under no circumstances be used in the EU. Even if it's trained outside the EU, it doesn't matter, you cannot use it in the EU. Then we have things that are high risk, and that's, for example, in healthcare, like diagnostics that I just showed you. Obviously, the consequences of something like that going wrong are severe. So that's a high risk, and that's governed by a certain, let's say, regulation behind that. We also have limited risk where, chatbots and things, it depends what they're generating. If they're generating, I don't know, public policy, that's a problem, and that's a risk. But if we're doing things like video games or things that are relatively low risk, there are less stringent regulations. There are some compliance requirements in terms of risk management, in terms of where you're storing your data, how you've trained it, what data you've trained it on, and obviously the human oversight that we talked about. It's really important that we document exactly what we're training the AI on. And that sounds silly, but if you're just throwing your net out and scraping the web for your stuff, your documentation is unlikely to be really very good. And then we talk about copyright. That's a really interesting area as well. As we said, there is controversy over who owns Gen AI output, because is it the model? Is it the person who trained the model? Is it the person who used the prompt to get the art? It's kind of complex. So that's something that's going to be coming out in a couple of years. Training data sets must respect copyright law and IP protections. I know that hasn't always been the case, especially for large language models that have been trained on almost the whole web. No one has sort of explicitly given permission for those models to be trained on their data, and yet it has been done. So there are still some, or rather now there are actually quite stringent laws about what things you can use that have to be explicitly marked for example, Creative Commons open source. And then there is an interesting exception that I think is relevant for this community, and that is if the model is open source or research focused specifically, then we are exempted from some of these regulations. So if we're looking specifically at university research, for example, we are able to bypass some of the more stringent copyright restrictions, for example, or more stringent risk prevention restrictions. And then we had a whole session at the end of our staff week just playing with AI and creativity and just trying to see what it can do. I think we kind of came to the consensus that generative AI is a tool that that will help us creatively express ourselves, not hinder it or sort of take it over, just like other tools have been in the past. There was a spirited debate about whether it can fully replicate human creativity. I'm of the opinion that it's going to be able to generate things that we cannot per se sort of distinguish from human de novo creativity, but there are others who feel differently. And obviously, as we mentioned, the copyright, for example, this image that we produced using DALL-E is still unclear who that belongs to. So just to take home, the AI and allied technologies such as extended reality are paving the way for us to change how we screen patients, how we write patient documents, how we train for surgery, how we navigate during surgery, how we predict complications, and we reduce post-operative pain, and a lot more, I'm sure, that I haven't mentioned today. I want to thank our group, the Leiden Amsterdam AI group, that I'm very lucky to be a part of. It's a big sort of multidisciplinary group with lots of different people that are really committed and working hard to making these tools accessible and effective in the healthcare space, as well as our international partners who work with us on that as well. And with that, I'd like to thank you very, very much for your attention and welcome any questions you might have.
Thank you very much for this very interesting and very comprehensive